Good afternoon. Welcome to today's program. My name is Amy Lipset from Professional Development at Thomas Jefferson University Hospitals. I'm going to quickly review our disclosure before we begin. Thomas Jefferson University Hospital is an approved provider of nursing continuing professional development by the Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. RN participants who successfully complete this activity will be awarded a maximum of 1.25 contact hours. Successful completion includes participating in the entire program and completing the online evaluation. You will receive this evaluation on Monday, and it will be open for 30 days. We have no disclosures or endorsements of products for today. And now it is my pleasure to turn today's program over to Dean Marino. Thank you.
Good afternoon, alumni, faculty, staff, students, friends, and Dean Sudha, Roddy, and our colleagues across the globe at KLE University in India. I want to extend a warm welcome to all of you on behalf of the entire Jefferson College of Nursing team. My name is Ann Marino, the Dean of the College of Nursing. We scheduled today's visiting scholar lecture in celebration of the Year of the Nurse and the Midwife, and in honor of Veterans Week, because JCN has a strong commitment to empowering nurse scientists and supporting military. In fact, we are honoring one of our own next week by awarding retired U.S. Air Force Colonel Meg Carey the Distinguished Alumni Award. But today, I could not think of two better people than today's visiting scholars who exemplify the epitome of nursing and midwifery science through their inspiring and collaborative work with military nurses. We originally planned today's program to be in person for alumni to visit us on campus, but that was not possible due to the COVID protocol. However, we are thrilled that the Alumni Relations Office could present today's presentation via Zoom. It enabled us to further connect with alumni that are located outside of the Philadelphia area, and to also connect with our partners at KLE University that are joining us from India. This will be our first alumni event of many more to come. Before we get started, I would like to applaud the efforts of all nurses, nurse leaders, nurse practitioners, nurse midwives that are here with us today. I know how each and every one of you are committed to improving and saving lives on a daily basis through your amazing academic, clinical, and scholarly pursuits. And now it is with great honor that I turn it over to my esteemed colleague, Jefferson College of Nursing's Associate Dean for Research, Joanne Robinson.
Good day or good evening, depending on where you are in the world. I'm Joanne Robinson, and I'm very pleased to welcome you to the first in a series of remote visiting scholar presentations that we are offering with Jefferson's Alumni Office. Generous support from the Stratton Foundation allows us to make this series possible, and we thank them. Today's session is titled Nurses in War, Learnings from Vietnam to Afghanistan and Back. And I have the pleasure of introducing our visiting scholars. First, Dr. Beth Scannell-Desch is a retired U.S. Air Force colonel with 25 years of active duty and a final assignment at the Pentagon. Following her military career, Beth moved into academic nursing, where she attained the rank of professor and served in a variety of administrative roles at Rutgers University in Camden, New Jersey, and Adelphi University and Mount St. Mary College, both in upstate New York. Beth has over 25 database publications in national and international peer-reviewed nursing journals. She is also the recipient of 9 research grants and has presented her research all over the world. In recognition of these accomplishments, Beth was awarded the Sustained Professional Achievement Award and the Rita Koff Memorial Research Award, both from the New York State Nurses Foundation. Beth's program of research focuses on women's health and military nursing. She co-authored 2 books, Nurses in War, Voices from Iraq and Afghanistan in 2012, and Nurses After War, the reintegration experience of nurses returning from the Iraq and Afghanistan wars in 2016. She currently has a nursing education consulting business and teaches as an adjunct professor at Mount St. Mary's College in New York. Beth's twin sister, Dr. Mary Ellen Doherty, is currently a professor of nursing at Western Connecticut State University in Danbury, Connecticut, where she teaches across the curriculum in undergraduate, graduate, and doctoral nursing courses. For most of her career, Mary Ellen has practiced as a certified nurse midwife and is the founder and president of Concord Midwifery Associates in Concord, Massachusetts. Mary Ellen is also an active nurse scientist and has conducted many studies in the area of women's health and midwifery care. Mary Ellen was the 2012 recipient of the Norton Mizvinsky Award for Excellence in Research at Connecticut State University. She co-authored both books, Nurses in War and Nurses After War, with Beth, and they're still speaking to each other. Along with Beth, Mary Ellen has presented her work all over the world. Currently, Mary Ellen is studying post-traumatic growth in women who have experienced loss, close brushes with death, and emotional or physical abuse. In 2020, she was named a fellow in the American College of Nurse Midwives in honor of her distinguished contributions to the field. On a personal note, Beth and I first met as baby docs or new PhD faculty at Rutgers University in 1997. To my delight, our paths keep crossing. Through Beth, I have come to know Mary Ellen, Beth's other half, and it has truly been a double your pleasure experience. I have enormous respect and admiration for the work that both of them have done and continue to do, and I am so excited to have them at Jeff to share this work with us. Take it away, Beth and Mary Ellen.
Thank you, Joanne. And I'm asking, I hope everybody can hear me. But anyway, it's a delight for both of us to be with you today. And let's have the next slide, please. Okay. How did it begin? Okay, well, as Joanne said, my background is in the Air Force. I'm a retired colonel in the Air Force Nurse Corps. I spent almost 8 years overseas and the rest of the time in the United States. And I am a flight nurse, as you can probably see in the picture of me next to one of my planes and with my wings on my uniform. But anyway, so how did I decide to first do my first study back in 1990, 91, and 92? Well, in looking at the literature, there really was not much written about back then about the contemporary military nurse in Vietnam. And my dissertation chair said to me, you need to write something that you're passionate about. You need to study something that you're going to have staying power with. Well, what am I passionate about? I've always been passionate about military nursing and the valuable contributions that nurses make in healthcare and in serving our country. So the title of my dissertation is listed here on the slide. Next slide, please. Okay, I have 5 publications on different aspects of my dissertation study because I got a wealth of qualitative data when I conducted this study. The first article was published in Image, the Journal of Nursing Scholarship. And what I looked at was the lived experience of women military nurses in Vietnam during the war. And some of the themes are listed here. You know, the description of the nurses' situations, the images that they have of Vietnam, etc. Next slide, please. More of the themes included facing the moral and ethical dilemmas, especially because many military nurses worked in the triage areas. And the rest of the slides you can see here, the rest of the themes. Okay, my second article was looking at the images and relationships forged in war for this same group of 24 nurses. And the thematic findings are listed here. When I talk about images, I don't just talk about visions, but the nurses talked about the sounds, the smells, and the thoughts they had when they heard the word Vietnam. They talked about 5 particular relationships, and they're listed here. One that I would like to point out is the description of special patients. It seemed that each nurse had 1 or 2 patients that years later she could tell me about. She could tell me their name, their age, what type of injuries they had, maybe where they hailed from back home. But every nurse had a patient that she carried the vision of in her heart. Next slide. The next article that I did looked at the culture of war. And this was published in the Journal of Transcultural Nursing. And when I looked at culture, nurses described the assignment to Vietnam, whether they were a volunteer or a non-volunteer, what it was like when they arrived in Vietnam. Many arrived in the middle of the night on an airplane that all the lights had to be dimmed, and they were coming in for a landing. They saw fire in the distance. They saw explosive ordnance going off. And they were quickly hurried off the plane to get on a bus. And they wondered why the bus had chicken wire over the windows. And someone explained to them that it was to prevent the enemy from throwing grenades and other ordnance into the bus. A scary beginning. The rest of the themes are listed here on the slide. The next study that I did, looking at an aspect of my dissertation, was the hardship and personal strategies of Vietnam War nurses. And this was published in 2000 in the Western Journal of Nursing Research. Again, the same 24 nurses gave me information about their hardships, what it was like to be overwhelmed by casualties in a mass casualty situation. They talked about their clinical experience or inexperience, because many of the nurses, this was their first assignment as a registered nurse. They went right from officer orientation and basic training to their first assignment, a hospital in Vietnam. They talked about one of the things that was the most difficult thing for them, and that was having a soldier heal in their hospital in Vietnam and then returning him to combat. The rest of the themes you can read. They also talked about their personal strategy themes. You know, what were some of their coping mechanisms? What type of diversional activities did they do to try to preserve some semblance of a way of life that they were used to, such as joining the hospital and chapel choirs, forming a softball team, visiting orphanages and helping the nuns in that endeavor. Also, use of alcohol and other drugs. Yes, it happened. Next slide, please. The last article that I had published on the Vietnam experience was in the Journal of Advanced Nursing, also in 2005. And this was where the nurses imparted advice and guidance to future generations of military nurses who may have to go to war. They talked about journaling and how keeping a journal was important for them. They talked about how the training that they get prior to deploying needs to be realistic as it can be made. They talked about the things they had to do in caring for themselves, and the rest of the themes you can read. In 2001 to 2005, I took sort of a research detour, if you will. I shifted from looking at military nursing for those 4 years to looking at another topic that was near and dear to my heart, and that was women's adjustment to widowhood. And the first article that I published was adjustment to widowhood. And this was a state of the science article. It was not a research article. And it looked at what's the theory that's out there about widowhood, what's the research, and what interventions are people recommending. And one of the reasons I got into this, there are two reasons. One, probably the one that's most foremost in my mind, is that my best friend lost her husband to a brain tumor, and that left her with a 14-month-old and a 7-year-old. And there wasn't much out there about widowhood except in the geriatric literature. The other reason was I became a widow myself in 2000. So anyway, this slide you can read, and it just talks about some of the fact-finding information that I got from doing my research in order to write this article. Next slide, please. So I did a study of 10 midlife widows, and they came from all walks of life: teachers, housewives, secretaries. One was a military wife. And they talked about 6 different themes that they encountered: struggling before the death, how they juggled family responsibilities, how they financed care before the death, and then struggling after death, looking at the emotional loss as well as the financial impact of their loss. Also, it came up with 2 main themes of triumphing of self and triumphing of environment. Next slide. And my next article looked at narratives of support and non-support in this same group of 10 midlife widows. And the support themes and non-support themes are listed here. Next slide, please. Okay. And now I turn it over to Dr. Mary Ellen Doherty.
Thank you, Beth. Can you hear me?
Yes.
We had a meeting of the minds with a study that I really developed after 9/11. I have to tell you, I'm a nurse midwife, as was said before, but midwifery is etched in my heart, in my soul, and in my mind, and women's health. And for some reason, I have always been led in this direction. As a midwife after 9/11, I wanted to do a study on the pregnant widows from the 9/11 events and from the wars in Iraq and Afghanistan. And I knew I wanted to do this study after I read Diane Sawyer's article in Life magazine and saw all the pictures. I knew there was nothing in the research literature about pregnant widows. And I knew I wanted to do this, but I thought it was in my best interest to do it with a research partner because I knew I would be dealing with very difficult and heartbreaking stories. So I got an epiphany in the shower and called Beth, knowing that Beth had done some research on widowhood, and said to her, "Do you think we could do this study together?" And we both had thought either it would be a wonderful endeavor or we would argue all the time and kill each other. Well, it ended up being a wonderful endeavor. And we did the lived experience of widowhood during pregnancy. And this was with 10 widows, and it was published in the Journal of Midwifery and Women's Health in 2008. And you can read the findings here, the 8 themes, and I will just give you kind of a synopsis of them. The realization that the partner or spouse was not coming home, that the woman had to navigate the pregnancy either alone or hopefully with other supportive people, that she had to plan for the birth, possibly going to childbirth classes by herself or getting a friend or relative to go with her, gathering a band of sisters to support her through this journey. A bittersweet homecoming. How difficult it must have been to bring your baby home without your person. It was definitely an unplanned journey. Many people had support, but some people were surprised that they did not have the support that they thought they were going to have. They were let down by others. And then they had to recreate home, a new normal. Next slide, please. We got back on the military nursing track together, and we both were interested in experiences of nurses doing nursing in Iraq and Afghanistan. Obviously, Beth, with all of her military experience, that was really what prompted her to be interested. What prompted me to be interested was that I was teaching in Massachusetts, and I remember in my maternal newborn class of baccalaureate nursing students, quite a few of them being plucked out of my class in the middle of the semester because their National Guard unit got called up and they were deploying within a week. And we kept a place in the class for them for when they returned. But it was quite a shock to them, and it was also quite a shock to me. The other group of nursing students that I had were seniors, and they were on ROTC scholarships. And once they graduated, after going usually to Fort McCoy in Wisconsin for training, they went right over to Iraq and Afghanistan. So literally their first job as an RN would be in an ICU or ER or similar unit in a hospital in Iraq or Afghanistan. Okay, the thematic findings from this study talked about deploying to war, how they found out, living conditions, a mixed bag. They might be living in a tent with 75 of their best friends, or they might be in a trailer or in a tent. Diversions from war, a piece of home. Many of them tried to create a home-like atmosphere in their living place. Remembrance of war, a most chaotic scene. I remember one nurse telling me in an interview that there was a particular instance that she will never forget. And she said it made her so sick that she had to go out in the back of the hospital and vomit and throw up because it was so horrible. And this was when 3 soldiers were in a Humvee, and their Humvee went over an IED, improvised explosive device. And within seconds, all 3 men lost both of their legs. The explosion caused a traumatic amputation. And these 3 were brought into her emergency room. And after they took care of them and stabilized them, it just got to her and she had to go outside and be sick. Many of the people, as Beth said before with Vietnam, remembered certain soldier patients. Next slide, please. Nurses talked about children being caught in the chaos of war. They all were surprised at the number of pediatric cases that they had. And it often reminded them, the ones that were parents, of their own children at home. It was also very difficult for them to care for the enemy. They might have a US GI in one bed and an insurgent in the next bed. Very hard to wrap your head around that. Nurses were injured as well. They were in harm's way, and many of them didn't realize that this was going to be the case when they were in a hospital. Kinship and bonding, their military family, they grew close, very close to their colleagues. Wartime stress, they were changed forever. How can you go through an experience like this and not be changed in some way? Homecoming could be a difficult adjustment, even after they waited for months and months and months to finally go home. It was not always as easy and as joyous as they thought it was going to be. professional growth. Everyone said they expanded their skills. They surprised themselves too. And the last thing was listen to me, advice for deploying nurses. The nurses that came back had such an important role in preparing nurses that were going to be going. Next slide, please. The first study that I just talked about informed us to do the next study. And this was women's health and hygiene issues or experiences while deployed in Iraq and Afghanistan. And this was published in the Journal of Midwifery and Women's Health in 2012. Especially in the early years of the war, the nurses were appalled at the way they had to live sometimes. And it depended on where you were. Let me give you some descriptions that go along with the thematic findings. Wooden latrines with holes in them. Reminds me of Girl Scout camp, actually. Porta potties. Standing in line for a very quick shower with lack of privacy, water shortages, lack of hot water, and dirty water. They were told not to open your mouth in the shower because the water is dirty, and please don't brush your teeth with that water. You need to get bottled water to brush your teeth. Menstrual periods. Some suppress them with Depo-Provera injections or with continuous birth control pills. Other people let nature take its course, although sometimes the hygiene supplies were scarce. It was hard to stay clean. Next slide. It was hard to stay clean, and women were subject to various infections. Like the picture on the bottom right-hand corner of the slide shows a leg with sandfly bites. Now, I mean, you would not normally get that in the, here in the United States. Nurses reported taking care of soldiers, female soldiers with unintended pregnancies. In other words, they became pregnant in the war zone. And many of the pregnancies could be easily concealed with the type of clothing that they wore, their military fatigues. So yes, there were babies, full-term babies born in a war zone. Because if they didn't have time to ship the soldier back to the United States, she had to give birth where she was. There were also safety issues, enemy attacks, and sexual assaults. Nurses, and all females were warned to take a buddy with you to the bathroom in the middle of the night because it might not be safe. You could be jumped, you could be attacked, and it might not be the enemy. It might be some of friendly forces. Next slide, please. The third study we did in this vein was nurse parents deployed to war. And the reason we did this was in the first two studies, nurses told us that the hardest thing for them was leaving their children back home. Some of them said they worried more about what was going on at home than the risks they were taking in a war zone. They were worried if the children, if they were young, would remember them. They worried about children getting help with homework. They worried about children getting their driver's license. They worried about kids going off to college and possible experience with alcohol and drugs. They worried about keeping in touch. Would the connectivity hold up in the location that they were stationed? The internet, phone calls, the mail, all of those things. And it was very difficult to care for war-injured children, for the parents, because the children often reminded them of their own children back home, especially if they physically resembled their own children, or if the ages were very similar. They worried about childcare arrangements. When mom and dad were both deployed, it was even more of a burden because maybe grandma and grandpa were taking care of young, energetic children. Next slide. Journey to our first book. Our first book included the experiences of the first 3 studies, and they're listed here. The first one was a catch-all, wartime experiences of nurses. Beth and I encouraged them to tell us everything and anything they wanted to. And then we focused on women's health and hygiene issues while deployed, because in the first study, that was a primary theme. And the third, deployment experiences of nurse parents, was also a primary theme. So we never thought we were going to write a book. We didn't set out to write a book. We set out to do nursing research on this topic. But I don't know how we got convinced to put these 3 studies in a book, but we did. And it was published by Springer Publishing Company in 2012. Next slide. After the book came out, we started focusing on reintegration experiences because it was difficult for many people. And we wanted to find out, what do they have to say about and it was 35 nurses, about their homecoming, about their adjustment. And the thematic content is listed here. Homecoming could be positive or negative or a mixed bag. They had to renegotiate roles. Maybe mom was gone, or maybe dad was gone, or maybe both of them were gone. And so this could take a toll on the family as the roles were renegotiated. It was also very difficult for deployed folks to get away from their painful memories of trauma. Some would have flashbacks. Certain things would trigger memories. Some people had nightmares. And then they had to decide if they were going to try to get help from behavioral health, mental health, counseling. They had to make a decision. Some people worried if there would be a stigma attached to this. Other nurses craved a clinical change of scenery. They had had enough trauma in the ER or ICU. And they said, give me maternity. Give me a nursing home. I need a clinical change of scenery. Nurses also commented on the lack of tolerance of some of their coworkers who complained about petty things. It was hard for them to accept this after what they had faced, after what they had been through. Some nurses returned to military active duty assignments with support, and others didn't have the support they had hoped for. Others were in the civilian sector, and they may be the only nurse in that facility, hospital, clinic, whatever, who had ever deployed to war. And so they didn't really have people to share their experience with or to relate to, and it was difficult. Their military unit or civilian job could be supportive or it could lack support, the same as family and social networks, support versus lack of support. Next slide, please. I just want to add, reintegration for the nurses was a real new normal. So our second book came out as a result of that study, and it was also published by Springer Publishing Company. And it talked about reintegration, and it also talked about resources for veterans that had issues with reintegration and how they could get help. And as the years went by, more and more people did decide to get help from behavioral help or on the outside or from support groups or the VA. Next slide, please. Beth, you're going to take over here with our last study.
Yes, this is our last study, and it was published in the Journal of Nursing Scholarship in May 2020. And here we also changed our methodology, if you will, for studying. But we called this a positive side of deployment, vicarious post-traumatic growth, not stress, growth in military nurses, et cetera. And we had 282 military nurses in the study. It was a mixed method study, as I'll go into in a minute. And the purpose was to assess, and examine post-traumatic growth in this population of nurses. Next slide.
The definition of post-traumatic growth. This term was coined by two psychology professors at the University of North Carolina in Charlotte, and they were Tedeschi and Calhoun. And they are still the primary researchers, I think, in the world on post-traumatic growth. The definition is that a person experiences this type of growth, goes beyond resilience, and exceeds previous levels of functioning. In other words, in some way, their life is enhanced or becomes more positive. Next slide.
Okay, our study design was a convergent parallel mixed method design. And we thought, how are we going to do this? So what we wanted to do was have an online survey of some sort using the post-traumatic growth inventory tool by Tedeschi and Calhoun and the core beliefs inventory done by Kahn et al. We also wanted to add a qualitative piece to this study. So we reviewed the literature very carefully and came up with 6 open-ended questions based on what we found in the literature. And the way people consented on an online survey was just to click to affirm their consent. Next slide. Okay, so how were we going to collect data, and who was going to help us with these online platforms? Well, we decided that we thought it should be open for at least 4 months on the internet. So I approached the Society of Air Force Nurses, the Army Nurse Corps Association, and the Navy Nurse Corps Association, because they all had websites and had a robust membership. So I approached their officers and provided them with our study proposal, all of our IRB documentation, the letter confirming that we had IRB approval from Western Connecticut State University. And they said that they would post the instrument on their websites, the instruments. And it was a SurveyMonkey design that we used. And that these 3 organizations would also send recruitment emails to their membership at least once a month. And I think most of them did it all 4 months. And the inclusion criteria and the consent was addressed in the literature that was posted on their websites. Next slide, please. Okay, so our sampling strategy was purposive. We electronically advertised with the 3 organizations that I mentioned. So what did the final sample look like after the 4 months? These are the numbers, 282 nurses with the breakdown listed underneath. Next slide, please. Some sample demographics, just to give you an idea. We asked them for their current age at the time they were taking the survey. And the average age at that point in time was 46, but most of them were younger than that when they were deployed to Iraq or Afghanistan. And there were 65 men and 217 women in this study. And you can see the race ethnicity breakdown here, as well as the time in the military. I would point out that we were a little bit surprised by the high level of education that these nurses had. 62% were master's prepared and 9% were doctorate. Next slide, please. Okay, the study instruments, just real briefly, because I'm keeping an eye on the time. Post-traumatic growth inventory from Tedeschi and Calhoun has 5 dimensions. They're listed here as factors. and that totals 21 questions that they have to answer. The core beliefs inventory is a 6-point Likert, and there are 9 questions in that instrument about life events. Next slide, please. Our data was analyzed using SPSS version 25 for the quantitative data, and we used qualitative content analysis for the qualitative data. Next slide. Okay, this is a busy slide, and the next 2 are even busier. So I'm just going to give a quick summary. The post-traumatic growth inventory, the highest growth was in the category appreciation of life. The second highest category of growth was their own personal strength. And then the others are listed here in descending order. Next slide, please. This slide you can just quickly read because it's very technical. The only thing that I really want to point out on this slide, because you're going to have copies of this slide, or you can go on YouTube and see this presentation again, there was no significant difference for branch of the military, i.e. Army, Navy, or Air Force, National Guard, or Reserves, or any other variables. Next slide. More on the findings. Again, this is down in the weeds. And we go into more detail on this when we do a longer presentation. Next slide. Qualitative findings, the dimensional themes. Appreciating my life more now. I'm stronger than I thought I was. Many, many nurses said the statements about those 2 items. I'm embracing new possibilities on my own terms now. Spirituality is more than organized religion. And lastly, hugging those I care about as tight as I can. Next slide. Study conclusions. This study presents initial evidence that some nurses experienced some post-traumatic growth. The nurses' qualitative comments matched up with the quantitative scores of the PTGI, especially in terms of appreciation of life and in terms of evaluating their own personal strength. One thing that Mary Ellen and I have gleaned from all of our studies is that military leadership needs to continually give support to nurses in the war zone and after returning home to help balance their lives and foster a successful reintegration. And reintegration is not a one-size-fits-all. Every nurse has their own timetable and their trajectory. Next slide, please. Study limitations are listed here. Of course, external validity is limited because we can't generalize about the whole population of military nurses who deployed. And we can't make comparisons to prior research with military nurses in these wars or in any wars. There was no comparison group used. And the 282 nurses were members of the Society of Air Force Nurses or Army Nurse Corps Association or Navy Nurse Corps Association. And they voluntarily participated in this study. So there's 2 limitations there. One is that they were volunteers to participate in the study. The other is that they chose to join these 3 organizations because they're not representative of all nurses. What about the people that chose not to join these organizations? Next slide. I turn it over to Mary Ellen.
Implications for nursing. As Beth just said, nurses need to be supported by their leadership when deployed, but also before they deploy, while they're deployed, and after they're deployed. They need to know that their work is valued, that they will be cared for and not forgotten, and that their families will be looked after during deployment, that the families won't be left hanging. Possible interventions suggested by our 2 experts, Calhoun and Tedeschi, they suggested journaling about experiences and thoughts, peer debriefing in small groups, during deployment and during reintegration. Also support groups before and during deployment and after. Next slide. Recommendations. More research is needed on post-traumatic growth in nurses and other caregivers. Research studies need to consider the time since deployment. What kind of traumatic events did that nurse witness? The types of trauma, where they were in country, and what they were doing. What was their job? What was their assignment? The age at the time of deployment. And did they have RN experience before the deployment? Or was this their first real job as a registered nurse? We need more research on post-traumatic growth. And whether we're focusing on growth is helpful, but it's positive instead of always focusing on the negative aspects of the experience. So, I mean, all of our work in the vein that we're in right now is to see, are there positive things that can come out of negative experiences? Next slide. Thank you for attending our presentation. Also, thank you to military nurses. Thank you to nurses all over the world and nurse midwives. This is the year of the nurse and the nurse midwife.
And thank you both, Dr. Scannell-Desch, Dr. Doherty. We will now move into questions and answers. We received a large number of questions in advance, and we're going to try to move through them as time allows. If you do have additional thoughts or questions, you can utilize the Q&A button at the bottom of the screen. So to get things started, our first question deals with treatment. So do nurses receive treatment for PTSD after being in a war zone?
Yes, they can, but they have to avail themselves of the treatment options. They present usually with more vicarious war experiences. In other words, taking care of casualties rather than being subjected to rocket-propelled grenade attacks or IEDs. But the nurse has to avail themselves. Counselors are available at the VA, in the private sector, and if they remain on active duty with military behavioral health. But it's not forced upon people, and there's no timetable. It's an open option for them.
Wonderful. Our next question comes from a family nurse practitioner who says, I manage vets post-deployment. Do nurse vets manage PTSD differently than other vets?
Yes, some nurses do have PTSD. And as I said in my previous answer, they present with more vicarious war experiences than having being subjected to a combatant environment. Their memories are more than about the carnage they witnessed in their triage areas or emergency rooms, I would say, rather than being shot at. However, they still have, from the carnage they witnessed, some have nightmares, flashbacks, intrusive thoughts, and memories of terribly injured soldiers, children, and civilians caught in the crossfire of war. The bottom line is they can have PTSD, but a lot of times their memories are different. Mary Ellen?
I was going to say that being that they're nurses, many of them have a little bit more awareness of the symptoms of PTSD and can identify it in themselves, probably because of their nursing background. I also wanted to say that many of the nurses felt that they didn't have closure in that they took care of maybe quadriplegics, people with all limbs amputated, and worried about how these folks were going to continue with their lives. And the nurses often didn't know, when the soldiers were shipped back to Germany or to the United States, they often didn't know the ultimate outcome. And I think that was also very bothersome to them.
Another question, do you see a role for EMDR in preventing burnout among midwives and nurses?
I'll answer that. I'm a real believer in EMDR. And what it is eye movement, desensitization response. And not all therapists do EMDR. You have to be certified in it. The VA is using this quite a bit right now, and I'm not sure if the military hospitals are or not. It would probably depend on having personnel at that hospital who were trained in EMDR, but I think that it is helpful. And it's been around longer than we think. I probably should have written down, but it's been around for more than 20 years. It's just that it's become a little more popular. I don't want to use the word, maybe a little more prevalent because of success in treating veterans with it. But it's also good for anybody that's had any kind of trauma. I mean, it could be somebody that got mugged. It could be somebody that was in an abusive relationship. It could be someone that was raped, a bad car accident. I mean, EMDR can be used for a multitude of things, of negative experiences. And it doesn't erase the experience. It just helps the person to deal with it without as much anxiety as they did before. And I mean, I can't say that it works for everyone. I've sent students for EMDR because of, anxiety and depression during nursing programs. I'm sure with COVID, there's going to be people availing themselves of EMDR, especially the nurses who have been on the front lines in the hospitals.
Sure. And I think we have time for just one more question. If you could pick one key takeaway about the experience of nurses reintegration, what would it be?
Beth, do you want me to answer that?
No, I can. You can jump in after me.
That's because she's 9 minutes older,
and because I'm a colonel. But anyway, I would say that one takeaway that I had through all the research that I've done is that each nurse has their own unique trajectory of reintegration. It's not a one size fits all, as I said earlier. And, it's like they have their own map to get home. They have their own timetable, and people can help them along the way. But it's really up to the nurse, and each person's experience is unique. Different stressors and triggers bother different people, just like in many other traumatic situations. And Mary Ellen, do you want to add anything?
I just wanted to add that whoever the person is dealing with needs to have patience, needs to be understanding and kind and caring, and give them enough space besides giving them support.
That's a great note to end on. I think we all could use some space and support when times come.
Yes.
We want to thank both of you for a really, really informative and important presentation and for sharing these stories broadly in your writings and your research. For those of you who are attending this afternoon or this evening, wherever you are, we really appreciate your time. You can find our speakers' books at Jefferson's campus store, Amazon, or other fine booksellers. We also invite you to learn more about the College of Nursing's new postgraduate certificate program in advanced headache diagnosis and management. You can learn more about that at jefferson.edu/JCN headache. We have a number of upcoming alumni events that we hope that you'll find and you'll join us at. You can sign up at jefferson.edu/alumni events, including our evening with Dean Marino next week, where we'll present our Distinguished Alumni Award to Meg Carey from the BSN class of 1985. So we hope to see you again soon. In the meantime, stay safe and be well.